is Scott Cheney. I'm a urologist at the Mayo Clinic in Arizona. I treat prostate cancer and many other urologic cancers. Today we're going to be talking about active surveillance for prostate cancer. Prostate cancer is one of the most common cancers that's diagnosed in men outside of skin cancer. In the 1980s, with the development of PSA, or prostate-specific antigen, prostate cancer diagnoses went up considerably in the United States. And we were diagnosing prostate cancer at a much earlier stage. This has led to overtreatment of prostate cancer, where we're treating many patients who probably never would have died from their disease. They might not have ever known that they had the disease in the first place if it weren't for the PSA. The treatment for prostate cancer, unfortunately, has a lot of side effects that can go along with it. The two mainstays of treatment are radiation and surgery. In the early 2000s and even into the 90s, there developed this concept of active surveillance. And what active surveillance is for prostate cancer is where we know that you have prostate cancer, we know that it's been diagnosed, but we don't necessarily treat it right away. The benefit of that is that you don't have to go through the effort to get treated, whether it's surgery or radiation, the cost of treatment, and you can follow the cancer over time to evaluate whether or not it's going to develop into one of those bad acting cancers. There are many different schedules and methods for doing active surveillance, but in general, what this entails is periodic PSAs, and for me, I do a PSA typically every 6 months, and also periodic biopsies. I do my biopsy frequency, usually I'll do a repeat biopsy about 6 months after the first biopsy if it's a more intermediate stage prostate cancer. If it's a lower risk prostate cancer, for instance, a Gleason 3+3 or Gleason 6 prostate cancer, I will oftentimes wait 1 to 2 years after the initial biopsy to repeat a biopsy. Another thing that's developed recently is prostate MRIs, and that's another way that you can look for abnormal lesions in the prostate and might help to influence your decision on whether active surveillance continues to be appropriate. So with that schedule, I'll often see patients back, again, every 6 months. I'll do a prostate exam, the PSA, periodic biopsies. And there's a lot of times where you do not have to initiate treatment. Now, who's a candidate for active surveillance? Well, I would say that it depends on a lot of different factors. The most important factors are the characteristics of your cancer. Prostate cancer is staged as far as the Gleason score. That's the grade of the tumor under the microscope. The Gleason score is two numbers that are added together, and those represent the aggressiveness of the way that the glands appear under the microscope. Gleason 3+3 or Gleason 6 is about the lowest risk prostate cancer that we call cancer. Gleason 5+5 is the worst prostate cancer that one can have. Now, I would say that with regard to the grade of prostate cancer, when you look at the amount of cancer that's present, we want fewer numbers of cores that are positive for cancer, and the amount of each core that's positive, we want that to be a low number as well. With each core sample, we take about a 2 centimeter by 1 millimeter sample of tissue. And if the amount of cancer on each sample is less than about 30 to 40%, that's reassuring that you don't have a really large tumor. Other factors to consider when you're trying to decide if active surveillance is appropriate for you are your age. And if you don't have necessarily an expected 10 to 15 year life expectancy, sometimes it's better not to treat the prostate cancer because prostate cancer takes a very, very long time to harm you. Again, I think the perfect patient for active surveillance is somebody who has a low risk prostate cancer, a Gleason 3+3. They have very few cores of prostate cancer that are present. Maybe 3, maybe 4 or less cores that have some cancer in them. And of the cores of cancer that are positive, less than 30 to 40% of those cores are positive. There are some patients who have Gleason 7 prostate cancer, which is an intermediate cancer that can be observed over time. But I'm going to probably follow those patients a little bit more closely and be more aggressive about repeating biopsies. As far as the frequency of biopsies going forward, when do I need to have a biopsy? Because we all know that biopsies are not comfortable to go through. Typically, as I said before, I'll get a biopsy at 6 to 12 months after the first biopsy to confirm and make sure that the cancer is not more aggressive than previously thought. If that second biopsy is either negative or stable from where the other biopsy was, then I'll oftentimes wait 2, 3, maybe even 4 years before repeating a biopsy. If the PSA or if an MRI suggests that the cancer is potentially getting worse, that might move up one. I would get another biopsy at that point. Active surveillance is wonderful because it really does avoid the side effects of the treatment of radiation and surgery. And it has the benefit of identifying those cancers that are turning into more bad actors. We know from studies that cancers that are diagnosed as worsening in patients who are on active surveillance, you can treat them with radiation or surgery and get excellent oncological outcomes, where it's almost equivalent to patients who you might have done surgery or radiation initially. Another consideration for somebody who wants to go on active surveillance is something I call delayed therapy. And this might be somebody who has a prostate cancer that the doctor thinks is probably going to need to be treated. But delayed therapy is something where I'll tell the patient, you're probably going to need to be treated, but if you want to avoid the side effects of treatment and wait until it's absolutely necessary to treat, we can do active surveillance for a period of time and eventually act on the cancer once it becomes absolutely necessary. This is somebody who might have a couple of cores of Gleason 3+4 prostate cancer, somebody who has good erectile function and really does not want to go through the side effects of radiation or surgery and might want to delay the treatment down the road. And again, we know that treating them later will adequately treat the prostate cancer, prevent prostate cancer death, and you don't really lose anything by delaying that therapy. So again, in summary, active surveillance is, in my opinion, a viable option for somebody who's diagnosed with prostate cancer, typically a prostate cancer that is low or intermediate risk. It has the benefit of avoiding the side effects of radiation, which are collateral damage to tissues that are close by, and surgery, which are mainly incontinence and erectile dysfunction. You avoid the cost of doing the aggressive treatment right up front. There are some downsides to the active surveillance, which are the fact that you need to come in every 6 months to have a PSA checked, and you need to have repeat biopsies, which we know are not very fun to do. But again, the benefit is that you're avoiding that active treatment for prostate cancer. We think that patients who go on active surveillance really don't lose out as far as control of their cancer. And I think you typically will identify the bad acting cancers before they've had a chance to become more aggressive and more harmful. One word of advice that I have for patients, there's many patients who come in and they are so worried about the diagnosis of cancer that no matter what type of cancer they have, they want treatment. I think that is a big problem because we end up giving patients side effects from the treatment that they really didn't need. I've had several patients in my career who have had one core of low-grade Gleason 6 prostate cancer, and they just cannot live with themselves having cancer in their body, and they want to go through treatment. Now, it's certainly not unreasonable to go through treatment for those patients, but active surveillance in that scenario is much preferred to treatment. Think about the gain in function or prevention of loss of function with regard to erectile function and urinary continence that you gain by not having surgery or radiation. So I would say for those patients who really might tend to be worried about this type of thing, really think hard whether you really want to have the treatment. Listen to your doctor. Your doctor will follow you very closely, and he or she will be able to identify whether or not the cancer has worsened over time and needs to be treated. I want to thank you for listening to this talk on active surveillance. My name is Scott Cheney, consultant urologist at the Mayo Clinic in Arizona. I want to invite you to explore the website and the many tools that we have to help you to learn more about this disease process and to help you to make your decision on which treatment is right for you. Thank you again.